precision is necessary when margin of error is small, and this is very important, particularly when we are in an area where it is very important, where we have vertebral artery and spinal cord, and the deformity is significant, and the cord is just not there. Basically, it's all pretty sort of compressed structure, but it has its plasticity, so that's why it is surviving. So we should have real precision, and where the error is small. I'll just start with my lesson, which I had in 2011, where I came across this gentleman of 84 year, quite active, without any morbid other disease. And he was trying to sort of get some mangoes from the mango tree. And he climbed there, and then he fell, and he had all the following weakness and with bladder bowel symptoms. And he had significant incoordination and quadriparesis when he visited us. At that time, there is C1, C2, and his MRI sort of C2 fracture with significant cord compression. 2011, so we operated, but then probably he worsened post-operative, and maybe because of the vertebral artery injury. And I did come across few complications, and this was one of my worst complications, which I usually share in order to just make sure that nobody should face this in future too. So I'm from the era, like Dr. Shailesh said earlier, he's from the era of the myelography, and I'm from the era of myelography too. And we did not have enough lead aprons. And one of my colleague, he stole the lead apron and put it on the elbow guard. And we used to really put it when we used to go to the operation theater and cover our private part in order not to get the radiation. That was a scenario in our college days, in our residency days. So we all know, Hippocrates' oath is do not harm, and that's what we all follow. But at the same time, with the technological advances, we really should have do good. And in this COVID era, further extension of this oath is that protect yourself first, then your staff, and then the patient. So take care of the surrounding in the form of patient as well. So this is something which I will be just touching on this COVID era as well, how we have sort of, adopted technological advances. So change is the only change, which is constant. And in order to just highlight the era which probably, we have gone through, our generation has gone through in the osteoporotic fracture, the teriparatide has changed the practice completely. Same way for the fluorotic spine, multi-regional spinal stenosis, which you call as MRSS or tandem stenosis, double level. But the bone scalpel has changed the scenario. Same way, these complex territories, complex anatomy, complex lesions, complex regions like, C71, that's where this O-arm navigation and neuromonitoring has completely changed the treatment plans as well. And that is what we call this as a integrated operation theater suits, which are now going to be the probably future, as mentioned by the previous speaker as well. So the severe journey, we used to sort of, when we used to operate before this era of neuromonitoring, we used to say patient moved, we will just telephone everybody or other telephone the surgeon who is operating. We have a team of 5 surgeons. So somebody who is operating would say, sir, patient has moved. So that's what, the neurology has been maintained or normal. And then only we will have a cup of tea. That was the anxiety which we used to have. We used to use a lot of Solumetrol as well, because we were not sure, whether we have sort of handled the cord properly or not. And because of the neuromonitoring, that has changed the practice too. And we used to inform neurology after the patient is extubated and keeping the patient in neurology in the recovery room as well for few hours in order to just see and observe. So that was a scenario of this severe many, maybe about 10 years, 5, 7 years, 10 years ago. So the goal of surgery, coming back to the real goal of the surgery, after adequate decompression with reduction when necessary with implant fixation, what should be the goal? The goal should be implant radiation malposition. So implant should be properly placed with minimum radiation and without malposition. That should be the goal of a surgeon for the surgery and the optimum outcome. And in order to deliver that, what is most important is the workflow, surgical workflow. And that's what we can achieve with this integrated spine suit. And that's what basically, these are all neuromonitoring. Along with that, the factory navigated tools That's what changes the practice completely, because that's where it is really important, because you know what you are doing. Like that you are playing the game on the computer, to be honest with you, if you are aware of what the anatomy and what we have planned. So what is important is we should have really class 100 OT, and this is now very very important in this COVID era. We usually have the neuro monitoring, we have the drills which are all navigated, and you can see where the drill tip is going. So that is very important. Sometimes you intentionally bridge the medial cortex as well, and you know that you're bridging the medial cortex in order to grip the proper screw. So the bone scalpel has also made the life easy, and we have such two sets of the spine theater suits. That's what has made life really easy. And I would say the learning curve, I would say in opposite direction, it isn't that long. You can do things much much better way, and with the first few cases, and you are on. So that is very important. We usually have the operation theaters. We can see from one theater to the second theater and the third theater. So these are the things which really makes us live as well. You can see through and through what is happening in the other OT as well. We have dedicated staff. That is very important for these tools. This is very important for this the technological advances, because your staff should know what they are doing, and that is very important because of the dedicated spine hospital, I would say, because we have only one sort of specialty. So our staff knows what they are doing, and these 5 teams per surgeons, and our heartbeats are saved only because of these integrated spine suits, because the surgical complexities which we are handling now, we are able to really do it with more precision. And still there are few permissible limitations which I will share as well. So navigation enabling technology, it is enviable, I would say. If somebody has the navigation, it just superb. You can do things much much better. It is like camera. When you use the camera, what is the utility, and when you have one, what are the things that you can do with this. So that is very important, that once you have the navigation, you can use it in n number of cases and n number of indications as well. When anatomy is taught, but when the abnormal anatomy, varied anatomy is handled in this on operation theater, it becomes very difficult. And when you can see that abnormal anatomy on the screen, that's what makes life really easy and superb, because then you know what you are doing and what you're dealing with when the ankylosing cases, things like that. So AI is on its way, and I think that's what something we know. Intelligence, artificial intelligence, is going to be way ahead as well, as far as all the medical advances too. So indications, probably I would say indications for O-arm and navigation, probably in all the cases to begin with, because that's where you really want to get used to the thing. Then it is sparingly used, initially used for all the cases. Then you can use it for MISS, deformity, cervical posterior fixations. Tumors has been mentioned already by the first speaker. That's where really it is important. I think the Shailesh also mentioned about the same. Redo surgeries, redo fixation, where you want to really put the AI screws, goes into the sacrum and the ella, high grade listes. And when there is abnormal anatomy, when I mentioned about, the particular ankylosing and tumor cases, where this has become a real blessing as well. Aims to achieve learning curve, as I mentioned, it is not as bad as one thinks about. Avoid duplicating the unwanted steps. So you can really, if you start working after a few, maybe about 10 cases only, you will avoid certain steps. You will directly go zoom, you're on. Achieve better preoperative planning. If you really have planned it better, like all of a sudden they sit for a few minutes with the MRI and X-ray, and we plan it accordingly. Minimize the potential misplaced screws, reduce the OR time, and I would say there is zero radiation. Our maximum user has been our Devanand, and his badge shows zero radiation. So that is very very important, because we all go out when the OR shoot is taken. Just share as a surgeon, if I walk and do not show a few cases, just to share with you. This has been the Anki case, and it was like this. The fracture had displaced, and we were able to put these pedicle screws. It was C6 to T1 and T2. You can see that this was possible only because of the OM and navigation. So C5 to T2 screws we have put. Another case, which was a doctor who had osteoblastoma, you can see that case, and that was navigated. We removed the hole and mass, and we were able to follow him up with good movement as well. So this is something that you can achieve with this technology too. Another case, hemivertebra. These are challenging cases. The upper cervical hemivertebrae with Arnold-Chiari malformation, with the syrinx, with the lower DL junction, the scoliosis, so congenital anomalies, so all sorts of. And where you can see that, if you really want to do something there, you are having an abnormal anatomy, abnormal structures, and that was possible only with this O-arm and navigation. And that really has given age over the other. This was recently operated just before the lockdown started. So February 20. Another case to share, quadruparesis, and this was again C1, C2. You can see the odontoid invagination. And to be honest with you, if I share my own experience, I was not comfortable and convenient and to do such complex surgery. But now I'm able to do left, right, in and out, and I'm able to put the position, the cages as well. You can see that this was reduced, and patient who did not have zero on the pre-operative or the per-operative when we started the surgery, he did not have signals, and post-operative when we finished the job, he probably had all the signals regained as well. So this is something which you can really say is that good adequate decompression, and that makes your life comfortable as well with the neuro monitoring too. So those who use the O-arm, they say there is increased accuracy, there is complexity of the cases which really can be dealt with, zero radiation exposure, and performing the high volume of surgeries where it is very important because you do not want to bring your patient back again, and that's again considered as a blemish too for both surgeon and patient as well. And particularly minimally invasive surgery where it is very important. But those who are, it is a virtual imaging. As probably, the cervical has probably about a millimeter of the safety margin. And in the lumbar, probably 2 millimeter of safety margin because both are mobile. In the dorsal, probably, one can say that there is good safety as well. So because of the some movement occurring, you can say that, something means basically you need to know anatomy, proper anatomy you have to know. So non-users of this O-arm, they would say high cost. They will say lack of adequate training. I would differ there. Adequate equipment issues, I would again differ there as well. And there is learning curve. Again, I would differ there as well because we have been able to adopt our most, the guy who joined a year ago was able to immediately adopt the technology too. And disruption of the workflow, I would say in the fact the workflow is better with the O-arm and navigation. So the concerns are, which are usually said that surgical time is more. I would say no, surgical time is at the end of the day, it is better. It is sort of surgical time is saved. Cost of necessary equipment, yes. That is where I would agree to this concern. Necessary equipment, they certainly are expensive, but I repeat, my staff, our overall, the hospital staff, they're able to manage it so well that the cost has gone really down. But yes, if I have to share my experience about this particularly, when you buy certain things like the O-arm and navigation, we were worried about the radiation because radiation is going to go around, and that is where we ended up buying the glass between the two operation theaters. So that was also the radio opaque glass we had to buy. Another thing that was a challenge to take the machine into the operation theater, that was also a challenge as well. But I think all those things can be overcome by properly.
I don't know. It's a whole thing.
Certain technical points like 3D image, patient positioning, very important. Usually one spin is important for the 6 vertebra in the cervical and 4 vertebra for the lumbar, and lower thoracic 5 to 6 vertebra for the dorsal spine. So these are the technical points one really need to know. But if you really have the long segment, you can use the 2 frames as well. I'll cover that in a minute. So technical limitations can be overcome by 2 frames. And if the obese patient is there, beware that C7T1 junction may not be as good visible as the visibility, the accuracy, the anatomical landmarks may not be as good. So if you are operating C7T1 in an obese patient, make sure that you are slow with all the anatomical landmarks, and you are doing this with the good precision as well. So very important that obesity. Long distance frames, yes, sometimes you have to be closer to the frame. In the recently, we have been putting the frame without putting even the incision. We have been sticking the frame onto the body of the patient, and we stitch it as well. So you are not putting an extra incision as well. So that's what we have sort of learned over the period of time, and it gives equally good precision and safety too. Radiation to the patient, that's always been a challenge. but I'm sure, for patient, maybe 1 or 2 spins is not going to give too bad a radiation. And as mentioned by Shailesh as well, all the machines which are coming with the low radiation too. Few conclusions from the papers. They say that image guided surgery tools are associated spinal navigation. I think it is good in the armamentarium of the spine surgeon, which is something which is very good. I was talking to somebody in the US, and they say that, in all the operation theater, 8 OM, 8 navigation. Oh, what a luxury. I think probably all our operation theaters are in near future maybe equipped with the same armamentarium as well. Image guided OM navigation cannot replace the technical expertise. I think one really need to know this. Training of the spine surgeon, it is very important that one has to really have the open surgeries performed first and then start this complex equipments as well. Spine surgeons using this technology need to be aware of the pitfalls, which I mentioned, couple of pitfalls which I mentioned earlier. So that is what should be kept in the mind. So the experience of the Stavia, patient moved, we really do not really need to talk about this. Usually patients are all comfortable because we have the neuro monitoring going on. I do not remember now, last few, maybe couple of years, we do not use Solimetrol now. And we inform the neurology, yes, patients usually are well extubated, and all those 4 anxiety moments that has gone, and our heartbeats are saved as well with this newer and advanced technology too. So this was a challenge. This is the operation, OARM being rolled in. And we had to open all the lift doors, all the lift side panels, and even the back panel as well, in order to accommodate the OARM into the lift. Because you can't just lift it, from the stair. And we had to have special arrangement made as well with the liftman. So that was a challenge, but it was fun. When we ended up, putting the OARM on the first floor, and there was only 1 inch space, as you can see here, there, at the top. So that 1 inch space, which was very, unique space, we had to really measure it again and again. We had to align the lift properly, and then we had to put it there up on the first floor. Our operation theater is on the first floor. So again, precision is very important, as the sort of the dialogue into the flyer. Precision very important. Safety certainly is important because the lift may fall, and accuracy was again one of those things, where we had to really use. So Stavia journey experience has been technology, artificial intelligence. It's, I think, the way ahead. Junctional area, anatomical landmarks, when you do not have, that's where we really need to, this will give us the edge over the other. Redo surgeries, staff education, very important. We have so far, with the 2 OARM, 2 suits, we have done about 1050 cases till date, and about 80 upper cervical cases from 2004 till now. But the last 45 cases were just in last 2 years, and without major mishap. So this is very, very important. These are the critical data, and these are all documented data as well. So OARM provides accuracy and safety. I would say this artificial intelligence, or the OARM, enhances our abilities, but also it scales down our inabilities too, because there are cases where, we are unable to do certain things, and that scales down the inabilities as well, which is very important. So it is too good to be lucky, but I would like to be precise. So when the luck does not come in my way, I'm safe and I'm ready to roll. And that was Ernst Hemingway. So my sort of, our friend Ketan, this talk goes to him. And we have been using, sort of this OARM navigation, and particularly these respirator N100 filters for the COVID era. So I have put this COVID era safety, security, and suraksha, which can be achieved with these theater suits. And now we have addition of this respirator with N100 filters. As you can see that, this video can really, if it plays, then probably maybe, this is something that is the respirator which we have used. We have done about 25 cases in last 15 days. 23 are with the fixation, and we have always done the second spin, because we do not want anybody to come back to the operation theater because the screw is misplaced. And we discharge the patient maybe early, but we admit the patient 2 days prior. We go for the COVID test, temperature testing, and the CT scan, and follow up on the phone regularly, done every second, third day, because we do not want to miss any of these patients. I'm thankful to Parag Sancheti and Dr. Shailesh Hedgavkar and Sancheti Institute for allowing me to share my opinion and giving this platform. Thank you very much.